Hi, everyone, and welcome to the MEGIN Spotlights, where we shine a light on the people and organisations driving innovation in neuroscience and brain health. I'm your host, Zoë Etter. Today, I'm thrilled to be joined by two outstanding clinicians from Cincinnati Children's Hospital, Dr. Tenney, who is a Pediatric Epileptologist and Clinical Director of the MEG Lab, and Neurosurgeon Dr. Skoch. Dr. Tenney, Dr. Skoch, welcome to the show. Thank you both for being here.
Thank you.
Dr. Skoch, as a neurosurgeon, how did you first become familiar with MEG, and what makes it a valuable clinical tool in your practice?
I've been, vaguely familiar with MEG, ever since medical school. It's this kind of mysterious big machine, this towering thing. And in residency, in my training, I was already interested in epilepsy quite a bit. And so I attended our epilepsy conferences, and we did use MEG to add as a facet of our analysis. But I will say, compared to what we're doing here, and I don't know how much of that is time, I think the main component is just the familiarity, and people like Dr. Tenney, who are experts in it that we have here. We use it much more heavily here at Cincinnati Children's than I ever did in my residency training. And so I don't feel like I really had as good of an understanding of its value until I came to Cincinnati Children's.
That's great to hear. Dr. Tenney, can you walk us through how MEG fits into your clinical decision-making as an epileptologist? When do you typically choose to incorporate MEG into a patient's diagnostic and treatment plan?
Yeah. So it's become pretty clear over the last several years that, there are specific clinical indications for clinical MEG in epilepsy. And, I was fortunate enough to be on a publication where we kind of outlined 10 different clinical indications for MEG within epilepsy. And, if you look at that list of the 10 different indications, it encompasses almost every patient that we see that comes for epilepsy surgery evaluation. And, I think in terms of incorporating it into the patient's overall workup, I think one of the things that we may do a little differently than some other institutions that I've seen is that we sort of think of it as more of kind of a first tier test. So patients that we're evaluating for epilepsy surgery, they get the MEG the same time that they get their prolonged video EEG, MRI, PET scans, all the rest of the workup. The MEG is done at the same time. So then we have all that data that we can look at together, which I think is really the key. I think other institutions may use it more of a kind of a second line, a second tier test, so that they do the rest of the workup. And then if they don't have a clear answer, then they may move to the MEG as sort of a secondary test. But I think, our kind of philosophy here has been, to kind of do it as part of the initial workup for the patient.
That sounds really interesting. Now that we've heard more about your individual perspectives, let's talk about collaboration. How do you both work together to incorporate MEG data into surgical planning? And what do your surgical conference processes look like?
Yeah, so I can kind of start on that. So, our patients, when we see them in clinic, if they have intractable epilepsy, then, that's the point at which we think about whether they should have a sort of non-invasive pre-surgical evaluation. And, that's the time when, we order all the testing that'll be done. And like I said, I think almost every patient that we have that gets evaluated for epilepsy surgery gets an MEG as part of their workup. Here, what we do is patients will come for usually about a 1-week stay, and they'll get all their tests done during that entire week. So the EEG for 5 days, try to capture their seizures, but then also all the other testing over the course of that week. And then after that week's over, we kind of summarize all the data that we've collected, and we present that in our surgical conference. And that includes the MEG and all the other tests. And, that's an important place where we have, sort of a multidisciplinary conversation about all the data with the neurosurgeons, the epileptologists, or radiologists, neuropsychologists, to kind of, come up with the best next plan for the patient.
Yeah, and that's a very in-depth conference. In fact, Dr. Tenney and I, you'll forgive us if we have bags under our eyes. We just finished a 3.5-hour conference where we go through all these studies and look at them in great depth. And we have all our colleagues looking at it. And even if it's a case that the epileptologist may not be the primary epileptologist for that patient, everyone gets to weigh in and kind of review the data. And if there's questions about the MEG, Dr. Tenney's there, and we can ask him. And we try to move through these pretty quickly. So he typically remembers that might have been artifactual. This patient was having a bad day, or oh, this is a really good signal. So that can help us as far as how much we trust that data. And as far as you also asked about, how do we incorporate that into the surgical planning? Well, one of the nice things we can do is that a lot of our surgeries now involve using stereotactic navigation, which is kind of like a GPS system for the brain intraoperatively. And Dr. Tenney can export the MEG data in a DICOM format that we can then fuse with a patient's MRI or CT scan. And so if there's a very specific MEG target, we can pinpoint that very precisely in the brain and put an electrode right through that target. And that's very helpful.
That sounds great. Dr. Skoch, why is MEG-derived data particularly important for neurosurgeons? And what insights does it offer that you might not get through other modalities?
I think it's very helpful because it's a three-dimensional modality. And so, we're always thinking in PD, and your typical EEG, which is the cornerstone of your epilepsy workup, is really two-dimensional data. And so being able to have this PD data that can help us hone in on sometimes fairly specific targets. There's also the MEG also gives us data with different paradigms. So there's one MEG can give us different answers, and sometimes those answers can be discordant, and then we kind of have to pick and choose and see, which we think is more value. And that's where Dr. Tenney can kind of help us weigh those. But other times those things line up nicely. And when the different MEG analyses, show us that they're all lining up, and especially if they're concordant with other data, such as something that's on the MRI scan or with the two-dimensional EEG data, we start to put more and more faith into that. And that's where having that 3D structure that we can target in surgery really becomes helpful.
Thank you for sharing that. Expanding on that further, would you each be able to share a case where MEG significantly impacted the clinical decision-making or surgical approach for a patient? Dr. Tenney, should we start with you?
Sure. Yeah, the case that I've had thought about is actually a patient of my own that I see in clinic and that had a surgical evaluation. She is a 9-year-old girl. She has very frequent seizures, up to 10 or more per day. And she had been on many different seizure medications. Her MRI had been read as normal and non-lesional until we did the MEG. And so one of the nice things about our conference is that we have a very skilled neuroradiologist that works with us. And one of the things that he does is during the conference, he will re-review the MRI and the PET scan once he sees the rest of the data. So like the MEG data. And in this case, what ended up happening was that, he re-reviewed specifically the area where we saw the MEG sources were localized. And, he found a very subtle area of what looked like cortical dysplasia that had not been called on the MRI previously, and also the PET scan. So this was a very subtle, even very skilled neuroradiologists would have sort of gone right by that and not worried about it. But for this patient, it made a really big difference because identifying that meant that she had a much better chance at having a good outcome. She ended up having the stereotactic EEG that Dr. Skoch was talking about. She had a lesion electrode that was placed right through that area that was identified on the MRI and where the MEG sources were. And she initially had a laser ablation procedure to kind of destroy that area of tissue. Is very close to the motor region. And so her seizures improved, and then they improved for a couple of months, and then they came back. And then just recently, earlier this spring, she had kind of an open resection procedure to kind of like more fully take care of that area that looked abnormal. And when I was just looking today, she's done very well so far. She hasn't had any seizures, which is a big change because she was having 10 or more per day before that. So I think that's a really good example of how having the MEG can be helpful, and also how having this sort of multidisciplinary conference that we have where things can be sort of re-reviewed when we have all the data can really change things for the patients. Because I'm not sure that if we hadn't found that, I'm not sure that we would have gotten as good information when we did the intracranial EEG.
That's incredible. Dr. Skoch, did you want to share a case?
Yeah, I'll pick an easy one because it's one that I just did the operation 2 days ago. But MEG was really helpful in this case in that we kind of had localized the seizure activity to the frontal lobe, but we didn't really have anything much more specific than that. But there were 3 dipoles that came up on the MEG analysis, and they were fairly close together, but not a real tight gathering. And it turned out, though, that they were, if you looked at them just right, you could see them kind of in a straight line. And so we used that for a stereo EEG analysis and put an electrode that was planned to go right down the middle of that barrel to hit all 3 of those dipoles. And sure enough, that electrode was a hotspot for seizure onset activity. And so I think this patient, without that information, probably would have undergone a frontal lobectomy, a very big surgery. And what I did this Tuesday was just placed a laser catheter down that area and created a 1 centimeter column of ablation such that all 3 of those areas where those dipoles were eliminated. Now, whether or not that is successful or sufficient remains to be seen, but it's an opportunity. And we do know from other cases where we've done these selective, very small ablations that a decent percentage of these patients actually do reach very good seizure outcomes without having to undergo the big surgeries. So it's an opportunity that we just wouldn't have had without that cluster of MEG data.
That's amazing that you can try and limit the surgery. So looking beyond the clinical side, there's also an important institutional perspective. How has Cincinnati Children's Hospital made a return on investment having MEG technology as a pre-surgical tool in the epilepsy program?
So we have had MEG here for a long time now, for about 20 years. The very first system got installed in 2005, which is right before I came here as a resident. And I'm sure at the time, that was a huge undertaking to, bring an instrument like that into the hospital. We got a new system in 2020. So after 15 years, we kind of got a new system at that point. And so I was involved in sort of the purchase of that. I think that there's certainly a financial component to the MEG, and the hospital looks at, they do analysis on return on investment and that sort of thing. But there's also kind of a non-financial aspect of that as well, which is being able to have this and kind of what are the downstream effects of, doing a better job localizing people's seizures, having them have a better outcome. In our case, many of these patients are pediatric, so it's the difference between, a lifetime of seizure medication, ER visits, hospital admissions, and just overall sort of like health of the patient. And I think that the hospital appreciates that, that there are these kind of, sort of non-financial or not so directly financially relevant aspects to something like the MEG. I think that, we're kind of a regional tool here. So, 2/3 of the patients that we record with MEG are our own patients from our own institution, but 1/3 of them are patients that come to us from other places, adult and pediatric, and so from surrounding states. And over time, we've grown the volume of patients in both of those categories. And I think part of it is that I think when people from other institutions who aren't using MEG as often, once they see what the results can provide them with, I think then they sort of, they have a tendency to send more and more patients. And that's kind of what we've seen over time. So.
Oh, that's great to hear. So before we wrap up, let's look ahead. Could you share any current or upcoming research you're involved with related to MEG, epilepsy, or broader advances in neuroscience?
I'll start off, and then the person you really want to hear talk about this is Dr. Tenney. I am assisting him with some really interesting research projects that I assume is what he will want to talk to you about. But one of the things that we've been looking at is in pediatric epilepsy, temporal lobe epilepsy can sometimes be especially deceiving. Unlike in a lot of adult epilepsy, where it looks like it's coming from the temporal lobe and you treat the temporal lobe, the seizures go away, we're often fooled in children. And so that's because there's extratemporal sources that can be participating in the epilepsy network. And so being able to use virtual sensors is a trick that we can do with MEG to be able to detect seizure activity specifically wherever we want to look. So post hoc, we can point to parts of the brain on the MEG after it's been acquired and say, is there anything that looks like epileptic activity or abnormal interictal activity in this spot? And if we see hot spots outside of the temporal lobe and what otherwise looks like a temporal epilepsy, it can really help us with our evaluation to say we need to pause and use some other studies to try to find out if this really is a simple temporal lobe epilepsy or not. And that research has been really incredible. And again, I'll let Dr. Tenney talk about that because my role in that is much more minimal.
It's been really nice to work on this research project with Dr. Skoch, with one of my other colleagues, and we were able to do this study in a way where we all did sort of a small segment of it, but we were all blinded to the results that every other person was getting. And so I think that made it a really powerful study. I think, my main interest in terms of MEG research is really how can we do a better job with the data once we record it?
Yeah.
So, sort of the question of, the most common method to analyze the data are these single equivalent dipoles. But, does that really sufficiently explain a patient that might have a very extended network that includes the temporal lobe and other areas kind of outside the temporal lobe? Well, maybe not. And maybe there are some better ways that we can sort of analyze the data to kind of better kind of represent that complexity. And so, so we have, we've worked on this project for patients that have temporal lobe epilepsy and what we call temporal lobe plus epilepsy. And so I'm hoping that we'll be able to extend that into patients that also have frontal lobe epilepsy, which is another challenging group of patients that we have. The frontal lobe is very large. And so because of that, it's a challenge. There are a lot of areas of the frontal lobe that we can't see very well on EEG. And so that's another challenge. And then another group of patients that I'm sort of interested in studying are patients that have tuberous sclerosis. And we have a very large population of patients with tuberous sclerosis here. They often get epilepsy surgery to treat their seizures, but they're a very challenging group of patients because they have multiple different brain lesions. And so the MRI, things like PET scan tend to be not as helpful. And then they typically have pretty brief seizures. The EEG oftentimes is not so helpful. And so you're left with the MEG is really, one of the main tools. And so there may be better ways that we can use the data for those patients as well.
That's really exciting to hear. Thank you for sharing. So thank you both for being on the spotlight today, for sharing your expertise with us and giving us a deeper look into how MEG is enhancing care for patients at Cincinnati Children's. It's been a pleasure having you both on the MEGIN Spotlights today.
Thank you, Zoe.
Thank you.
Thank you.